Hi there. So I'm Taylor Abel. I'm a pediatric neurosurgeon at Children's Hospital of Pittsburgh. And this is George Ibrahim. He's a pediatric neurosurgeon at the Hospital for Sick Children in Toronto, Canada. We're both epilepsy surgeons. And actually, we've both worked together in the past, so we thought we would put this last talk together and kind of tell you about all three types of neuromodulation at once. We're going to try to move quickly because we're behind, but I also wanted to mention that I'm very open to anybody emailing me. My email address is widely available on the internet, and so if you have any questions and you don't have a chance to ask it, just feel free to drop us a line, at least me. George, you okay with that?
Please do. My
Yes.
email is equally available on the internet.
Yeah. And we know that because we get emails from patients, and it's actually great because when our patients need us, we want them to talk to us. So we're going to be talking about what happens if the seizures return, vagus nerve stimulation, deep brain stimulation, and responsive neurostimulation. These are all forms of what is called neuromodulation, where we are changing brain activity through stimulation. And with that, I'm going to hand it over to George for the next couple slides.
Wonderful. So just a few disclosures. Both Taylor and I do have some research funding. Some of my funding comes from the company that makes vagus nerve stimulators, but none of that is relevant to what I'm about to discuss with you this morning.
And then I wish I had conflicts of interest, but I don't. I just have research funding.
But we collaborate a lot. So I wanted to start by talking about epilepsy as a network disorder. So we've heard through multiple talks this theme of epilepsy as a network disorder, and I wanted to talk about some of the very landmark people and the landmark concepts that have emerged over the years. So there's two Americans, Jasper and Penfield, who did most of their work in Canada, who defined this area known as the seizure onset zone. And they thought that if you removed the seizure onset zone, you could take away epilepsy. Across the pond in France, just a little bit after, a few decades after, that's where the term the epileptogenic zone came from. And we heard that a little bit earlier today, and that's the part of the brain that you remove to take seizures away. And more recently, a lot of people have thought of epilepsy as a network where maybe you don't have to take away part of the brain, you could just change the circuit. And if you change the circuit at multiple points along this loop, as shown in this figure, maybe you can somehow improve seizures and maybe even make them go away. So from these different models of epilepsy as a network disorder, we essentially have all the treatments that are available to us. And there's three. There's really only three treatments that are available for epilepsy. If you know where the seizures are coming from, and you can find that one specific area of the circuit that you can take out, then that's a resection. You can make a patient seizure-free by removing the epileptogenic zone. If you can't pinpoint that area, or if that area is so large that it's very difficult to remove it all, you can disconnect it from the rest of the brain or the rest of the circuit, and that's disconnective surgery. And that's very much in keeping with hemispherectomies, corpus callosotomies. Those are the two classic disconnective surgeries. If you can't pinpoint the area, and if you can't disconnect the circuit, that's where electrical stimulation ties in. And electrical stimulation is what Taylor defined or described as neuromodulation, and there's three primary forms: vagus nerve stimulation, deep brain stimulation, and responsive neurostimulation. Maybe just by show of hands, how many people here have heard of or had experience with vagus nerve stimulation? Wonderful. How about deep brain stimulation? Okay. And responsive neurostimulation? Okay, wonderful. So those are the three areas that we want to delve into and talk about in much more detail.
Okay, so I'm going to take just the next few minutes and talk about vagus nerve stimulation, which is probably what most of you are most familiar with. So a lot of this is probably review, but but we're going to kind of go over it pretty quickly. So this is what the device looks like. The vagus nerve is a cranial nerve that's in the neck, and we implant a stimulator onto the vagus nerve through an operation, and then connect it to a battery, which is implanted in the chest. It's not really understood exactly how this works, but the thought is that it involves modulation of brainstem activity through the left vagus nerve that then changes brain activity to reduce seizures. The surgery is safe, well tolerated. There are a few side effects, but they're not very common or severe. But the problem is that little is known about how well it actually works. Particularly in children. The first randomized controlled trial was published with children older than 12 was published in 1996, and the first randomized controlled trial involving children younger than 12 wasn't published until 12 years later. And really most of what we know is from observational cohort studies, which is a lower form of evidence than a randomized controlled trial. This is a figure showing data from VNS registry data, showing that, and this is what we tell patients in clinic, there's about 50% chance that you will have 50% reduction in your seizure frequency. And that is about as good as I can do. Dr. Ibrahim is going to talk a little bit later about how we can do better, but that's about as good as we can do right now. Another point to make is that there's been this debate about how long you need to have a vagus nerve stimulator before it works. This is a figure showing here that at 3 months, that you have improved performance of the vagus nerve stimulator at 12 months compared to 3 months. It's maybe about 10% better reduction in seizure frequency. And then this is just a forest plot showing pediatric observational cohort studies that have looked at reduction in seizure frequency after vagus nerve stimulation. And the point here is not to look at every study on the figure, but the point is to look at where these lines are and where the dots are showing the change in seizure frequency, and just to see that they're all over the place. There's a lot of variability in the outcome in these studies, and it's probably reflected by the variability of the patient population in which we're using this treatment. And so with that, I'm going to turn it over to Dr. Ibrahim, who's going to talk about some ways that maybe we can improve our prediction of who's going to do well after the surgery.
So one thing that we're very excited about is the future possibilities of trying to define who the right patient is who will benefit from vagus nerve stimulation. So Taylor mentioned that about 50% of children will have a good response, greater than 50% response to seizures, and 50% don't. We are part, and we're actually leading a network of 13 centers across North America looking at this very specific question. When we take patient factors, age, what the seizures look like, what the EEG looks like, what the MRI looks like, and we try to use those factors to decide who's going to benefit and who won't from vagus nerve stimulation, we actually do a very poor job. It's a flip of a coin. We have no idea who's going to benefit and who won't from vagus nerve stimulation. And this is what's shown in this picture. The blue circle are those that respond, and the red circle are those that don't respond. And if you look at the blue and the red circle, they overlap perfectly. We have no idea. We have no idea how to tease apart the responders and the non-responders to vagus nerve stimulation. So what we're doing with our large network across North America is looking at brain connectivity. We're looking to see how the brains of children who respond to vagus nerve stimulation differ from the brains of children who do not respond to vagus nerve stimulation. We're looking at how the brain is wired differently and how that difference in wiring predicts responsiveness to neuromodulation and VNS. This probably doesn't mean much to most of you, but essentially this tells you how good anything is at predicting response. If it's more diagonal, that tells you it's the flip of a coin. And these are all the clinical predictors that we have available to us to determine who's going to respond and who won't. And that diagonal line across the graph there tells you that we're no good using clinical predictors than flipping a coin. when we look at how the brain is wired, and when we look at differences in connectivity between responders and non-responders, some of our early data is suggesting that we can predict potentially with upwards of 90% accuracy. So this is something that our collaboration is working to advance to potentially predict who's going to benefit from this surgery and proceed with surgery in the children who are more likely to benefit, and maybe choose other options in the children who won't. And what are some of the other options that are available to us? Well, the next line of neuromodulation that is increasingly applied for epilepsy is deep brain stimulation. And deep brain stimulation is in many ways a novel idea, but in many ways it isn't. If we look at the history of deep brain stimulation, it's actually been around since the 1870s in one form or another. Now, over time, the technology has obviously advanced. We've learned a lot more about the human brain. We've become very precise, and we've been able to do it more safely. But the fundamental idea of using electricity to alter brain circuitry has been around for over a century. If we look at the number of publications that are published in deep brain stimulation, there's an exponential increase over time. And I point out here some of the landmark studies that have shown that deep brain stimulation is effective for multiple neurological conditions, not just epilepsy. Movement disorders, potentially disorders that have been predominantly in the domain of psychiatry, and certainly epilepsy. There's been over 100,000 patients that have received DBS electrodes across North America, and the primary indications, though there's many and they're expanding day by day, are pain, movement disorders, and epilepsy. And just so that you're all aware, this is what a deep brain stimulation electrode looks like. These are the electrodes. There's 4 little contacts that are implanted deep in the brain, and those 4 contacts deliver electrical stimulation. The way that those contacts are implanted is stereotactically, meaning you put them in with millimeter precision so that they end up in the target that you intend them for in the very depth of the brain to alter the brain circuitry that is essentially in the center of the human brain. And we do that by modifying a few different factors. We can modify factors related to the voltage, the frequency of stimulation, the electrode configuration, but the whole point of deep brain stimulation is to excite some circuits or inhibit other circuits depending on what you want to do, to dial up or to dial down human circuitry in order to see either increases or decreases in whatever behavior you're interested in. Obviously for epilepsy, the idea is to decrease brain excitability and to decrease or potentially eliminate seizures. This is what a system looks like. It's very similar to a vagus nerve stimulation system in that there is a pulse generator that's implanted in the chest, but instead of the electrodes being implanted at the neck like a vagus nerve stimulator is, it's tunneled all the way up to burr holes that are on either side of the brain, and the electrodes are implanted stereotactically in the depth of the brain. So the first use of DBS to treat epilepsy is probably in the 1950s, and the initial stimulation target was, oddly enough, the cerebellum, the back of the brain, which we don't usually think of as a target for epilepsy, but that's the first one that was tried. And these are the many targets that have been now attempted for deep brain stimulation. Some have been proven with randomized trials, but the vast majority have not been. The vast majority have been prospective, controlled studies in surgeons placing these electrodes and seeing benefits in patients after deep brain stimulation. This is the one large trial of DBS for epilepsy of the anterior thalamic nucleus, and I'll push forward in that to the next slide to show that the efficacy of DBS is very similar to the efficacy of VNS. There's about 50% reduction in seizure frequency, and just as we mentioned earlier, there's about 50% reduction in about 50% of patients. So that number is extremely, extremely common across many of these modalities that we choose. And our challenge moving forward over the next 5 to 10 years is not necessarily to introduce new surgical treatments. It's to better understand the surgical treatments that we already have. It's to try and decide which patient is more likely to benefit from vagus nerve stimulation and which patient is more likely to benefit from deep brain stimulation. Because we feel, and we're very excited about the fact, that we can tease out differences between these two populations and offer the right treatment to the right child. When we look at deep brain stimulation for children specifically, it's less commonly used. This is a paper that Taylor and I wrote, I think last year or 2 years ago, where we looked at all the literature for deep brain stimulation in children. And there's about 21 studies of deep brain stimulation in children, and that encompasses at least 40 patients. There's probably more now. In Toronto, we just started a deep brain stimulation program, and we just placed the first deep brain stimulation device last year in a child, and we're building this program forward to offer this therapy to more children. But as it stands, this is a younger treatment for children than vagus nerve stimulation. It's less established, but moving forward, our challenge and our opportunity is to try and define which child will benefit from this versus the other neuromodulatory treatments that we have available to us.
So I'm going to speak very briefly about responsive neurostimulation, which is an even newer form of neuromodulation than DBS, and we have even less information about it, particularly in pediatrics, though we actually have quite a bit of good information in adults. But this is a form of closed-loop neurostimulation where you have a stimulator that is also connected to a sensor. The sensor detects when seizure activity starts, and then the stimulator then stimulates a region of the brain to try to stop the seizure. And this is some clinical data showing that if you compare two groups of patients with responsive neurostimulators, one group where it's turned on and one group where it's turned off, the group where it's turned on does better, and they have a lower seizure frequency. In pediatrics, there are very few of these operations that have been performed. This is one report in a child as young as 9 years old who has been seizure-free for 4 months after 21 months of using the device. I know just from talking to people that more people have been doing this in pediatrics, but the experience is very limited. Our adult program is very experienced with this technology, and so we're actually starting a pediatric RNS clinic at Children's Hospital of Pittsburgh. And it'll be really interesting to figure out exactly which of these treatments is best for which patients. This is just a figure trying to tie everything together. It compares the results of VNS, thalamic DBS, and cortical stimulation with RNS. And what it shows, it's by John Ralston, he published it back in 2012. And what it shows is that after 1 year of using these, they all seem to be pretty similar. And so really the question is, which of these is best for which patient? The machine learning connectivity work that Dr. Ibrahim is doing and that I'm happy to collaborate with him on might give us some answers to that. But one potential treatment algorithm right now is if you know where the seizures are coming from, but it's in an area that you cannot resect, say a polymicrogyria in motor cortex, RNS might be an option. That's direct stimulation of the polymicrogyria in an area where you can't remove it. If you have a limbic focus that you can't resect, anterior thalamic DBS might be the best option, according to the Sante trial. And if you have something else going on, like generalized epilepsy, for example, or multifocal epilepsy, centromedian DBS might be an option. Centromedian RNS is something that we've done at Pittsburgh. Or maybe doing vagal nerve stimulation first. That's what we have the most experience with, and perhaps trying one of those other options later on.
And really, one of the main conclusions that I think you've heard consistently through all of these talks is that any decision is really not myself, not Dr. Abel, not any of the neurologists in isolation. It's a big multidisciplinary team, and really the leader of that team is the child and the family. All of these decisions have to do with how the seizures are, what the experience of the child with the seizures are, and how we as a multidisciplinary team can help the child. So at the very core of it is the child, the family, and all of us on the periphery are helping. This is our first child who underwent DBS at SickKids in Toronto. Dr. Abel had just left Toronto, so his picture is on this.
I wasn't actually there, but I was working on this slide at 10 p.m. and slipped my photo in there without George knowing it.
And we miss him dearly in Toronto, so he is a huge asset to the United States and our loss in Canada. But with that, we'll conclude our talk and take any questions that you may have.
And also, I'm talking about hydrocephalus at some point today. We're a little behind, but if any of you come and have questions, that would be a great time to ask also.
So we need to run to our next sessions, which start in 1 minute. The sibling panel has already started. They're teenagers. I'm sorry we couldn't stop them from talking, so go. They have agreed to stay for lunch. We have pizza. I'm sure you never have pizza, right? And we'll see everyone back here at 12:30 with your kids. You have to get them before 12:30 from Kid Camp. Sorry, this is going to be a rushed next hour. Thank you very much. That was terrific. Thank you.